Welcome back to the Clinical Athlete podcast. If you're not familiar with Clinical Athlete, we're a network of healthcare providers, students, coaches, and trainers who specialize in the management of athletes. You can find your nearest Clinical Athlete provider at clinicalathlete.com. We also have a forum where we discuss and share ideas and resources related to sports med, athlete rehab, and performance. To join the forum or for potential listing on the Clinical Athlete directory and for all upcoming seminars, webinars, and events, details can be found on the website. This podcast can also be found on the website along with YouTube, iTunes, Google Play, Spotify, Stitcher, and iHeartRadio. My name is Quinn Hennick. I'm a doctor of physical therapy in Orange County, California at Clinical Athlete Newport. I'm joined by Jared Maynard, who is the Clinical Athlete Continuing Education Director and Coordinator and a physiotherapist at King Physiotherapist and Foot Clinic in Ontario, Canada. He is a certified strength and conditioning specialist and runs an online powerlifting coaching company and is a competitive powerlifter himself. What's up, Jared?
Not much, man. Just chilling, literally, because we got more snow on the weekend.
Are you serious?
We were clear of it. Oh, yeah.
Yeah.
My God, man. It was 70 degrees here in Southern California.
I mean, it's no explosion of the butterfly population like you got to deal with over there. You're really slugging it out over there.
Right? Listen, we've talked about the mudslides and the earthquakes and the wildfires. We have our hazards.
Yeah. Oh, well, you didn't talk about the biggest one, which is the butterflies.
Stop. You're trolling. Greg, we had a little bit of rain here in Southern California, so we had a wildflower boom and an influx of butterflies. It was amazing and beautiful.
Yeah, everyone knows that.
Jared's making fun of it.
No, I'm serious.
And our boy John Flagg couldn't make the show. He's feeling a bit under the weather, but really I think he just didn't like our guest. Just kidding. John loves Greg. So no, he loves you. Speaking of, okay, we're super excited to welcome physiotherapist, chiropractor, and strength and conditioning specialist Greg Lehman onto the show. Greg, thanks so much for being on.
Yeah, thanks for having me.
It's an honor. So for those who don't know, one of the courses that Greg teaches all over the world is called Reconciling Biomechanics with Pain Science. The title of the course encompasses the work that you put out really well. And so we wanted to get you on the show to talk specifically about lumbar spine biomechanics, when and how they matter, and with respect to the science of pain. But before we get into that, can you tell our 6 listeners a little bit more about yourself and what's led to these interests that you're so passionate about, and ultimately to the pinnacle of your professional career now, which is being on the Clinical Athlete podcast?
Yeah, thanks. Well, I'm primarily a clinician. I'm teaching a lot more now than I ever have, but I was in clinical practice for 15 years as a chiro, and then I went back to school for physio. And before that, I did a master's in spine biomechanics at Waterloo. But when I was at Waterloo, I was also a strength coach with the Laurier's basketball team. That's like the university down the road, and then hockey team after that. So I've always loved biomechanics, but and I still think it's really important. And that was the thrust of the course is I think biomechanics is important. Let's not ignore it, but let's find another more valid way to utilize it with our patients and athletes. That's sort of the big idea there. And so I've always been interested in the little questions and things that we say in the clinic that may or may not be supported. And I think so much of what I do is I'm really on the fence with a lot of this stuff, and I have my own doubts, and I just like to share my doubts with everybody else, so we can all commiserate together. And so that's and that's what we'll talk about. You'll see, I don't think we should have really strong opinions on some of the topics that we have really strong opinions on. When you know the research well, you should feel a little confused, and that's okay. And so my goal was with creating the course was to find a way to navigate that doubt and still practice in a healthy and useful manner with patients and athletes.
We're all just swimming in an ocean of uncertainty.
Yeah, it's okay.
Yeah.
You just got to navigate that. It's fine.
Embrace the void.
Embrace the void. And then what I find so neat is once you go through the complexity of the biomechanics and different sides of things, often when you come out, it's really simple advice from what we know. And I'm why did we spend so much time talking about these issues when some of it's just common sense? And I still think that all the debates that we have in practice, it really doesn't matter. when people who look very different and how they choose to do certain things, whether it's working with an athlete or someone in pain, they actually, they're disagreeing about the little details. But what if you turn the sound off and just watched what they did, you'd be like, oh, they're really kind of similar, but they just don't want to admit it.
It's also the difference, but these discussions typically refer to hypotheticals and made up constructs that we're looking at a kind of a snapshot in the moment. In the clinical setting, when we're taking into account prior history, current status, future goals, the background of the individual, what they're dealing with at home, what we're able to get in during our clinic session, what they're able to do at home on their own. All these factors just encompass so much that make a discussion like that truly like a one-off discussion damn near impossible. And to provide some context to that type of thing, you've spoken many times regarding what seems to be, but is most likely a false dichotomy, as most things are, between the movement, quote, movement quality model and the, quote, movement optimist model. You're more an advocate for the movement optimist model, but can you speak a little bit about what that is and why you tend to advocate to that over alternatives?
Yeah, so that I wouldn't even... First, I would challenge the term movement quality. I want to even take that definition away from the classic definition. So the classic way it's defined is the kinesiopathological model, which means we have pain or injuries or future injuries when you move, the kinesio, when you move in such a way that's different from a proposed ideal. And that ideal in general is more being neutral, like alignment, no scoliosis, don't deviate, not a lot of spine flexion, that sort of idea. That's the kinesiopath model. If you're running, your knees shouldn't cave in. If you squat, your knees shouldn't cave in. You should minimize hip internal rotation. Your scapula shouldn't wing, it shouldn't shrug. That's the kinesiopath model. And some people would say, well, that's movement quality because that's how you should move. And I would contrast that with the movement optimism model, which is all of those positions are okay to some extent, and it kind of depends on what your goals are and how well you can prepare yourself to get into those positions. So it's more and so me being pithy, I say movement preparation trumps movement quality. That how we move, that you've prepared to do something. So I think we've freaked out over these biomechanical boogeymen, and we're ignoring the variables that are more important. Would be if you're going to deadlift, well, it doesn't matter what your technique is if you just jump in and start doing 12 sets 5 days per week with poor sleep and poor recovery. No one would do that, but let's say you have some idiot that does.
Someone's done it.
Sure. Yeah. It's my rock climbing.
Would you say on the other side, there are patterns that emerge when you're exposed to a repeated stressor? Let's just say lifting. There's an economy of movement that emerges over time for an individual, and we can maybe coach somebody into that economy of movement,
Yeah, totally. I mean, we still have a huge role for performance specialists and strength coaches and technique advocates. But you nailed it. You said it's about economy and about efficiency and performance. And so maybe biomechanics and how we move is probably more important for performance than for pain and injury would be the argument, right? And so, but I'm still again on the fence. I'm sure I do have instances where I would say how we move is important even for injuries as well. I boulder or rock climb, and when I jump off of stuff, it's certainly better to land on my feet than to land on my hands, and there's probably a better way to land, a lot of motion through my knees and my hips and my spine rather than landing stiff, and not absorbing that. So there, you know what I mean? There's still better ways to move, and it's not totally irrelevant. But the things that we've been harping on for years, those are the things where I'm they might be important at the extremes. Like if it looks pornographic, like, the Supreme Court definition of pornography, it's hard to define, but you know it when you see it. And so like, maybe if you have like pornographic movement patterns, you're more likely to get injured. So I don't know if they've come up with an FMS subscore on the pornography scale. Greg Cook's listening, and no doubt. That's the new version. We are coming out. It's the pornographic capacity and the pornographic quality, and we thought of it first. Cost $400.
Yeah.
We just lost half our listeners. No, but it's not the first time we've talked about the FMS on this show. And then the follow-up question is, if you see that type of egregious movement, can you even do anything about it? Again, it comes down to the context of the situation, or do you need to? Do you feel that there are adaptable ceilings? Because I know with the movement optimist model, it's about let's embrace adaptability. Let's embrace uncertainty, but embrace adaptability. And I don't think we don't give our bodies enough credit for what they can absorb and adapt to. With that said, and I think you kind of touched on it a little bit, do you feel that there are still kind of adaptability ceilings for certain structures or within certain patterns?
Absolutely. And that's what we need to know more about, is like how different tissues and people respond to load, and when we need to back off and when we need to go ahead. Like, I used to run a lot, and I would get around, 80, 90 kilometers a week, 50, 60 miles. And that was trouble. I'd start to break down there. Or like with gymnasts, so actually, let's have another way of looking at movement quality here. I call movement quality having a lot of options to do the same task. That's what like when I see a good mover. I was in Florida teaching with Brian Bushett, and he has a CrossFit boxing gym, and he could just move however he likes. He has like beautiful classic technique, but then he could move any other way. And so to me, I'm like, if we do have an adaptability ceiling and you want to keep training, then ideally you can start moving a different way and unloading those tissues as they recover and keep doing other stuff. That kind of makes sense to me. That's the new movement quality to me, is like keep training number of different ways and then keep adapting and spare some tissues, give them a break and load other ones and build up. Right. That's my bias. It's like, I definitely think there's a limit to adaptability. So train differently sometimes. Pretty groundbreaking, eh? Yeah. Sorry.
Well, the have options for the same task is, I think, defined movement variability is that's like by definition. I think I've seen that in the literature several times. To have several options to perform the same task, but and it's that finite window of your variability is constrained when you first learn a task, but it's like a bell curve. It's like too much noise, too much variability, and you can't quite hone in on the skill. Too little and the system is too rigid, but there's that kind of Goldilocks zone that comes with just deliberate practice and learning, and time, enough time to adapt. If we're talking about the lumbar spine in particular, because it's still taught, as far as spinal flexion being an injury mechanism, and that as a standalone is taken to, then we shouldn't flex our spine. Ergo, spinal flexion is bad. With the adaptability concept in mind, what your thoughts on teaching lifting technique from somebody who's not necessarily a lifter? So I think we're all on the same page that biomechanics matters from a performance perspective, force transfer, all these things. We start talking about injury risk and potential sensitization, maybe over time with some positions versus others. If you had a newbie in front of you who had a job to lift things, what is your approach in regards to spinal position? Long-winded question.
Yeah, no. I would say don't worry about it. Work on figuring out the way that you can lift the most weight the easiest, and that's where I think coaches are excellent. That's why like good strength coaches, and I'm not one of them. I'm more into like programming and stuff like that. I'm not like a powerlifting coach, that's for sure, where a good coach will look at the person and be like, okay, these are your options on how to lift. And that's why it's so interesting when you see good lifters, how there's so much variability. right? And some of it's anatomically based and all that. So I would assume someone who has a job when they have to lift over and over, teach them, they're probably still going to use their hips and, get their ass back and down and things like that. But don't think about the spine flexion. You'll use your spine position to get the rest of your body parts in the best position to produce force. And then I would say with our occupational athletes like that, probably the more important thing, and we see this in the literature, is that they're prepared to lift. That's why, like on the Cochrane reviews, they have interventions where they go and teach people how to lift to do their job. Those things in general don't seem to decrease low back pain. But when they go in and add exercise programs and build up these people and their resiliency, that seems to decrease pain. Right. So it's not the technique, it's the preparation that maybe seems more important. Yeah. That's my thoughts on the occupational lifter. If that what you meant? Like someone has a job has to lift shit?
Absolutely. Yeah.
That's the thrust. Don't worry about the spine position. Get the spine position in the position that allows you to produce the most force, the most easily, with the most ease.
Is it kind of one of those things where you can find a starting point, like the traditional, just kind of flat, just kind of pat people on the back and just tight, just stay right here, keep that where it is, or something like that, just in the beginning.
Yeah.
And then let the patterns emerge from there. Just take a step back, see what they do over time with increased load or increased stress, speed, whatever it is, or volume, something like that. If things start to become inefficient,
something,
then you step in, intervene, something simple, step back, let the patterns emerge. And, that's a process of preparation right there. But it sounds like your point is you're not putting them in the optimal position because there may not actually be one to begin with. And you're also not worried about necessarily keeping them there in this rigid pattern over time.
Yeah. I mean, like you're not going to, if you're going to lift the most weight from the floor, no one's going to choose, you're not going to Jefferson curl, right? So although the spine's fully flexed in those positions, there are biomechanics that are important to produce more force. You want to get your hips back and down and all of those things, but just don't get caught up on the spine position. That's probably not important. But I would say, like guys like you that work with athletes to produce more force, I'm not sure everything is like, I don't know these terms, the self-organizing system. I don't know if it's just fully emergent that people can figure it out on their own. Mm-hmm. Just me learning gymnastics as an adult, right? I can watch as many YouTube videos as I want. It helps. But I was like, today I really needed a coach who was helping me figure out a way to do a certain movement. It wasn't coming on my own, right? So I'm not always sure that it's like self-emergent or that the best way to do it. We all figure it out. So there's still a role for coaching and physios and all that stuff. Totally.
If a student reads one of your articles, watches one of your videos, listens to you talk here, maybe even goes to your course and comes away with the notion that biomechanics now don't matter, what's the biggest thing that's being misinterpreted? Where does the pendulum swing too far?
Yeah, if they come up with that conclusion, then I've done it wrong. That's my fault then. Or they probably if that ever I have had people do that, but then they haven't really read my stuff. That's the thing. Or they have a preconceived idea of what I'm going to say, and then they just skim my blogs and stuff like that. So if they come up with that, what they're missing here is what I'm saying is the biomechanics that you think matters. Those ones don't matter, but there are other ones that are important. That's what I'm saying. Like I find it's the biomechanical research itself that contradicts the status quo of the biomechanical like ideas that we have out there. I think if you know the biomechanics really well, then you start questioning what so many people teach and accept. So I'm saying biomechanics are important, just not the ones that you think are important.
It also sounds like you're saying that it's very context dependent too. So it's hard to pass or have these overarching statements that hold true for everybody in every situation, because it's probably going to vary quite a lot.
Yeah, it's true. And I agree with Stu McMillan, who he doesn't like the term "it depends."
Okay.
He always says that, and he's like, "Fine, it depends." So give me the situation why it does depend. And so I always try to do that. Like with the shoulder, I don't really care too much about scapular position and scapular kinematics. But at the same time, I think those that theory led us to training the scapulothoracic muscles and the rotator cuff, and that seems to be helpful for a lot of shoulder pain, but it doesn't change scapular position. So to me, the mechanics don't matter, but the training impetus to train that whole region and train comprehensively, that's a really good thing to do. So the mechanics are still important here, just not how you move is the most important. Or if it hurts to do something, well, dumbass, don't do that. Like, change your mechanics temporarily. And then if you're open to the movement optimism idea, then you can start doing weird things or different things with your shoulder. Keep moving, it desensitizes, and then you can go back to moving however you like.
I've also heard you say, sorry, go ahead.
No, that's it.
I also heard you say that if something hurts, another option is persist and, see if you can adapt to that.
Yeah, that's super neat, eh? And like,
it's groundbreaking.
And you know what? People have done that forever.
Yeah.
Like, you just kind of work around. But the joke. The people that do that, we don't. They don't come and see us.
That's right. Yeah, exactly.
Like, there's plenty of people solve their pain problems that way. I love that idea of like, okay, find the thing that hurts, and the assumption is you haven't adapted to that. Back it off. Find the right dosage. Treat with the poison and then adapt to it. It's movement homeopathy. That's what it is. That's my new joke. That's my new one. I'm running with it. I need a t-shirt. Right? Like that's what we do all the time. What are you having trouble doing? Okay, do that, but do less.
Yeah, for sure.
It's true. I had a patient today. Like the inside of her ankle hurts when she runs, right? It flared up, but she did a 20K run at speed the other day. So it's not too bad, but I'm not going to change her running technique. I've known her for years. She's not changing it. She's not tolerating those movements. All right. Well, these are some of the exercises you're going to do. The thing that kind of hurts.
Right.
That's what we did. Well, in 2 weeks, she's doing other stuff initially, and then she'll do that.
Right.
Yeah.
In those cases, do you find you get the question that, hey, what should I do? I'm having this issue. What should I do? Do you ever find yourself rebutting that to say, do you need to do anything? Would you be okay with not doing anything to address this issue and just letting it be? You ran 20K. Yeah. That happened. Your body's now telling you this, but it will likely not be telling you that if you just give it a little bit of time. Do you have those conversations with people?
Yeah, absolutely. And they often will email me and they'll have that conversation with themselves, and they'll like, so I know you're going to tell me to back off a little bit of running, but still do some. And they always write that. So I know I'm doing my job because they just don't fully have as much confidence in themselves as they need to. So yeah, that's a really neat concept of therapy. Like, it's like a tendinopathy. We always think you got to load up that tendon hard progressively, and it'll like heal, or it'll build new collagen, and it'll be able to tolerate the tendinosis. And what we've never really had research studies on is like, well, what if we just back off of what they're doing and they love to do, and then use, like, say it's sprinting or running, and then use the sprinting and running as the intervention to catalyze healing. Back it off a little bit, and then slowly start sprinting and running again, and change up those variables to stimulate the person to adapt. We never have studies on that, except in the hamstring strains. It's the, what do they say? It's like, it's sprinting is the vaccine, right? You tear your hamstring sprinting, so we're going to rehab you with sprinting, right?
Well, it's a dose response, right?
Yeah. So that's where mechanics matters. But it's not always the quality or how someone moves. It's like how much they're moving. Right?
Do you tier that at all? So we take the sprinting comment. We're getting way far afield for lumbar spine, but that's kind of flex a little bit. You not flex. It's going to happen, but whatever makes you feel strongest and most comfortable, done.
Yeah. There you go.
With sprinting's way cooler. With something like sprinting, do you tier your approach in what you recommend in that? So dosage is kind of king. It doesn't really matter how you're moving. If you do 100 sprints at RPE 10 constantly, then, it doesn't matter how you're moving. That's going to supersede biomechanics. Just dosage, just workload alone. There can be that argument. But within that, if we modify dosage, there are technical aspects of sprinting that can change strain on a tissue. Like, a sprint coach would say, if you're reaching your base, your contact point is in front of your body. We get that contact point underneath your body a little bit more. So now you're kind of pulling in more of a mid-range hamstring as opposed to that, extension of the knee and hip at terminal stance, something like that. But that doesn't supersede the dosage. So we've got to get that right. Do you have that type of mindset in regards to symptom modification or conversations? Or are you kind of just blending both?
So I shouldn't have brought up sprinting because it's actually the one where like sprinting and ACLs and stuff like that, where I think when tissue gets when the loads get so close to its failure rate, that's where I actually think the mechanics probably matter more, or they matter a little bit because it's such a fluke occurrence anyway. If they're right at 99.5% of their maximum threshold and they move a little bit funny on one stride, right, then they're in trouble. But if you probably worked on their sprinting technique and they had more of a buffer, then when they make that little error, maybe they're safe. So that's where I wonder mechanics might matter more, and sprinting is a good one. I think ACL tears probably have the same idea. Like, you definitely want to get strong in the quads and the hips and all that stuff. And that's probably enough to avoid the dynamic knee valgus. But maybe there's a few, like especially young girls, where you can train their movement patterns too, to not to go into that dynamic knee valgus with no knee flexion. It's the knee flexion that's the issue. Like, you can go into valgus all the time if your knee's flexed, then you won't tear your ACL. But so sure, I just went from the spine to hamstring to ACLs but it's all those. It's those. I wanted to avoid the it depends things and give you some examples of where the mechanics probably matter there. But again, going back to what you said, the dosage is probably the more important thing.
Do you feel that that same conversation would include lumbar discs in regards to spinal flexion and lifting, or does the literature maybe not necessarily say that because there's so much spinal flexion that occurs naturally with some of these tasks?
So my bias with the spine is the same as every joint. Like, to me, it feels like end range of every joint is probably a little bit harder on everybody, right? And like when I do back handsprings, catching the ground with your hands fully, like your arms fully overhead, that's pretty hard, and it limits the number I can do. If I can get my chest over my hips over my body more and not catch in that position, I can do more. So I think the spine's the same. Like, teaching to avoid 100% under heavy load is probably reasonable. But like with deadlifters, even really good ones, we know that they flex their spine 70 to 80%, right? And squatting is 50 to 60. So, I mean, I think that's fine, but it's just an end range that I would argue. I don't think repeated spine flexion like that is so bad when you're doing 60, 80%. It just doesn't seem like it's so horrible. And with deadlifting, how many reps would you guys do in a week if you're training hard? I know you don't never think of that, but what's the time under tension?
How many reps? Gosh, something like 20 to 50 probably.
Yeah. Like, who cares? Do you know what I mean? Like, it's nothing.
Yeah.
It's and how many, like with sprinting, how many steps do you take in a week? So much more, like 20 to 50. And then you have all that time to recover. Right. Why are we worrying about this? Right.
One of the things that you brought up is the uncertainty with adaptability of these tissues. Like, we don't actually have a great working model. Tendinopathy, I mean, collagen renewal, that's a black hole, because it doesn't appear to happen after a certain age, or if it does, we don't have the tool sensitive enough to pick it up.
It seems to happen on the outer core,
right,
more than the inner core,
right? Yeah. So it's like, and
not a lot.
No. And that's been studied a lot. And are you aware of any similar studies on lumbar discs in regards to their adaptive capability?
There are, I can give you researchers, and I've read their stuff, and it's confusing. Researcher named J.C. Lotz, been publishing for 20 years, has like mouse tail models and stuff like that. They load up mouse tails, so guess what? If you just compress a mouse tail for a month, it starts to break down. But if you compress it and relax and compress and relax, it's anabolic. It builds up, right? So load is good for the disc in a mouse if you work with mice. But they never, that's just neutral. They never go into, I mean, the boogeyman has always been flexion. There's so many research groups that show in a cadaver model, if you repeatedly flex a disc, it will delaminate. But they do thousands and thousands of cycles. And the big issue, of course, is that it's dead tissue. And I always say, like, if you took a tendon out of a dead person and you pulled it thousands and thousands of times, it would crumble as well. But we would never say, don't run. That's the...
Well, one of the arguments with the Jefferson curl, it was like in order to do the Jefferson curl is I'm creating adaptability. I'm giving myself a buffer. And if people aren't familiar with the Jefferson curl, it's just imagine the opposite of the deadlift that you would typically coach. Essentially, it's just full
from the top down.
From the top down, segment by segment. You flex one segment at a time from your neck to your lower back, as far as your tissues will allow, and you extend one segment at a time from L5 all the way up to your neck until you're in the standing position again. Rinse, repeat with progressive loads. One of the Christopher Summers, one of the old USA gymnastics coaches, anecdotally told me that he would have people he would have his athletes progress over the course of a couple of years, Jefferson curls holding a barbell with body weight for sets of 10 and standing on a box. And these gymnasts they have a lot of range of motion. And so, their face is basically at their toes in a Jefferson curl position, holding a barbell with their body weight. And they're doing these things for multiple sets. Then the argument was, we're giving them that buffer. And these are gymnasts, mind you, again, what's the cohort that you're talking about? Well, we're giving your tissues a buffer so that if you are subjected to a certain position, you will have been prepared for it. But what you're saying is we don't necessarily know. We're not doing longitudinal studies on the tissues to know what adaptations are occurring, really. No.
And it's actually, we just don't know how adaptable the disc is, right? And like, we don't even really know if the wear and tear hypothesis is supported. There's a number of researchers who have said, like, I believe in like using load to catalyze positive tissue adaptations. And I like to think that can happen with the disc too. But I mean, if I'm pretty honest in the literature, it's more like your disc is going to change just based on your genetics, right? There's really not much that you can do. Right. And the tendon stuff kind of supports a little bit of that as well, and so, but interesting. This is, I've heard, I was talking to, oh my God, what's his name? Dave Tilley. He's a gymnastics coach.
Yep.
And I was asking him about this idea that, if you do Jefferson curls or something, people say that will cause the disc to elongate, like the fibers will be like more flexible and allow you to have mobility, right? That's sort of the idea. But if you do deadlifts, it'll stiffen up the fibers. But what's interesting, and this is like a property of all connective tissue, this might surprise you guys, and your readers or listeners can go check this out, is that we're getting to just an idea here. I know of no research that shows that you can actually lengthen connective tissue besides pregnancy. Hold on here. This is why. When you strength train, we'll talk about tendons for a second. When you strength train, so the muscles are contracting, and what are they doing to the tendon? They're pulling on it, right? And so the tendon undergoes about 4.5% to 6% strain if you're pulling around 80 to 90% of your max. So the tendon stretches, and you hold it for a bit, and then it relaxes. It's a spring. And if you do that, every day or 3 times a week, as you pull on that tendon, meaning stretch it, it gets thicker a little bit and it gets stiffer, meaning the material properties of the tendon change. So does that make sense? The tendon becomes stiffer.
Yep.
Now imagine you're doing a stretch, right? A passive, boring old stretch. What are you doing to the tendon?
Pulling on it.
You're pulling on it. What does the tendon undergo? Strain. Like probably less than an isometric contraction, but it undergoes strain. Why would it lengthen now? Whereas before, when we pulled on it, it stiffened up. Do you know what I mean? So I'm sharing my doubt with all of your listeners here, because I found one paper that shows it get less stiff with stretching, but it actually wasn't stretching, it's dynamic stretching, not acute, not static stuff. There's surprisingly no literature showing how we can stretch tissue. So taking that tendon model to the disc, I don't see how we can lengthen, like make a disc more pliable. It seems like we can only make it stronger and stiffer, which would support what you said about that gymnastics coach doing those positions, right? It's not even the disc that resists flexion. It's all the other passive tissues. You know, the disc, if you go to 100% flexion or 90%, the disc is only contributing 95% of the passive, doesn't matter, but the passive extensor moments it's hard. It doesn't get loaded a lot. You got to go like way beyond like what the whole system can handle before you really start pulling on the disc. If you want the research here, it's Patricia Dolan, and this stuff is 25 years old. So I don't actually know that. I think you can just stiffen up a disc. I don't know how we would ever lengthen it. That would support the idea of the Jefferson curl, but I don't think it's a really good exercise to do anyway.
The connective tissue conversation is interesting, and now you don't know if it's a conversation of what's happening to the actual collagen or the matrix. Because when I dive into the tendon literature, to your point, there's a Baum Baum review in 2015. The nuclear stuff too, where it doesn't collagen turnover essentially is minimal after age 17. But the author's last name Bohm did a review in 2015 of Baum literature. Sebastian Baum, yep. And so I
thought you meant the bomb.
No, well that's part of the conversation. Is a tendon on average seems to stiffen with progressive loading. Stiffening is a mechanical property, but what also tends to change is the material property of the modulus. But I've seen a couple one-off studies, and they're after the Baum review came out, showing that eccentric loading caused a decrease in tendon stiffness. However, these are one-off studies of only eccentric loading. We don't know where they were necessarily starting from compared to the general population, and the windows of time are like 4 weeks. So in my mind, I'm thinking, is there kind of like an adaptation where if you are subjecting the connective tissue to constant stretch on strain, but in a stretch position, is there some material stretching that occurs initially, but then there's like kind of this upswing of stiffness that occurs if you were to continue with the loading program over time, something like that.
What was it, a Blazevich study?
I'll need to look. I'll shoot it to you. So there is a Kubo study.
He always shows stiffness increases. You're blowing my mind.
I'll send it to you because Kubo, the Kubo studies that I'm thinking of are like 2001, 2004.
Yeah.
And the reason I'm not prepared for this is because I wasn't prepared to talk about this. It's okay. But I will send it. I'll send it to you. And tell you, because I was very comfortable with saying that very just kind of easily that tendon stiffness increases with increased loading, and then and I came across a couple studies that I wasn't as comfortable saying that. And I was kind of the
only person I know who says that doesn't increase stiffness is Jeffrey Verrill's work out of Australia, and he cites a Blazevich paper. But when you talk to Anthony Blazevich about it, who's a sports science researcher out of Australia, he's like, no, it's the muscle stiffness that decreases. Like stretching will decrease muscle stiffness and sensory stiffness, but not tendon. That's what he says with the eccentric stuff. So I would go back to I want to see that, Quinn, if you can send it to me. But I would just wonder if it wasn't muscle or somewhere like maybe there's something right around where muscle transitions into tendon, and that might be where we can get a stiffness change, like to decrease or something. The only way I know how to decrease tendon stiffness is bed rest and injury.
Yeah. Jared, say something so I can look.
I think I know what you're talking about. It's a patellar tendinopathy rehab program. They showed a decrease in stiffness.
No, that was a heavy slow resistance. That's another one. These were healthy tendons. So that's another one.
So I don't know. So that's a weird one because you just load up a tendon when it's injured, and in the patella it gets less stiff. But that means once it gets healthier, at some point in time, it has to get stiffer.
But there was a Consgard article on the patellar tendon as well, using the same exact protocol, and they found an increase in stiffness. So it's just this. Yeah. It's like, it also comes down to what measuring tools are you using. And Scott Morrison brought this point to me, is that all of these studies have such small sample sizes. Is it possible that we're so myopic in who we're looking at that we're missing any type of big pattern, because maybe we are taking 12 people that their tendons happen to decrease in stiffness when we look at this, and then we're like, oh shit.
Yeah.
But then the Baum article is just another configuration of studies with small sample sizes. So it's just because you have an average of small studies doesn't necessarily mean that's generalizable either.
I don't know.
But yeah,
sure. I got you guys off topic.
No,
and this is what I mean. You get into the weeds of biomechanics like this, and if you use stiffness as a surrogate or a guide to rehab, it's just silly.
It's tough.
That's why you should just say, what attributes in you do we want to develop? Power, speed, strength, endurance, whatever it happens to be. Okay, that's what we'll do. What do you want to do? What are you having trouble doing? Okay, that's what we're going to do. Why do we even care about tendon stiffness? Right?
Yeah. Well,
it's the same thing back to the spine. Why are we even worried about it then? We don't even know how it adapts to load, so we're freaking out about it. If it hurts, maybe don't do it. Okay. Like, you know what I mean? It ends up being that simple sometimes.
100%.
Like, fuck.
Well, one of your papers, I think, takes this into account really well as a viewpoint in JOSPT last year, and I got it in front of me here. It's the role of value of symptom modification approaches in musculoskeletal practice. And so
yeah,
it's kind of goes back to what you have talked about earlier, was just give them options, let them play around and see if they can change something. Do that for a while, drive home the point of this may just be a temporary change, because sometimes that's a confusion point. Well, people think if I'm changing your movement, that needs to be permanent, and the previous movement was bad and was what caused this issue. Can you talk a little bit about that misconception and that paper in general? Do you have a way to teach people how to symptom modify, or give them like kind of a hierarchy of options?
Yeah, I do. Like, so I break, this is sort of the idea that a lot of people do. The point of the paper was, you have all these gurus and really well-respected people who it looks like they have very different ways to practice to help the same person. And I was like, what are the common themes? And the common theme that I think they find someone you find something that hurts, and then you teach someone some way to control their symptoms so they can keep doing that movement. But then really you get them back to doing the things that they love and they want to do. And that's like the biggest common theme. And then what they disagree on is like the ideal way for people to move. So in that paper, I compared Peter O'Sullivan's approach with someone who has low back pain and Stu McGill's approach, where someone will come in, it hurts to flex. They're afraid to flex. They avoid flexion. When they go to bend over, they don't flex at all. So they're an avoidance coper. And he teaches them, relax, breathe through your belly. You're safe to flex, slowly start doing it. And the person's like, oh, wow, I can flex. I feel fantastic. He doesn't say this is the right way to move and bend over. He say this is the right way for you right now. It's the George Costanza school of rehab. Whatever you're doing, do the opposite. And it comes out golden. And then the other model is the classic spine stability model. And I think these people are accidental. These people are endurance copers. They might deadlift, train hard. They just do lots of flexion. And for whatever reason, they couldn't adapt to that. And so the flexion pattern was now painful. So you're like, oh, okay, you keep flexing your back and it hurts. Here, I'm going to teach you not to do that. Right? But you're going to keep doing the thing that you love. So in that group, they try to do a more neutral spine. But they both schools of thought are, whatever you're doing, let's change that, get you to control your symptoms, and then keep doing the things that you love. That's it. Like, it's so simple. And then, sorry, you asked like, what's the hierarchy of things that people can do? If you're a therapist, I say like, just keep doing the stuff that you really feel comfortable with. Like if you already put your hands on people, that's the thing. That'll be one of your symptom modifiers. But find the thing that hurts, modify with your hands, and then get people to do it again. If you're like a spine stability person, you like to do spine exercises and all that stuff, well, find the thing that someone has trouble. Like say it's a hip adduction hurts. Well, take the bird dog, you know this one, Jared, we do this, I do this one all the time because that's what I do. Take the bird dog and now turn the bird dog not into a hip stability exercise, but an exposure exercise into hip adduction or spine flexion or extension, whatever it happens to be. Like I'm sensitive to spine extension years ago, but now I have to do it for gymnastics. So guess what I do with the bird dog? I extend the hell out of my spine. I try not to move from my hips. I move from my back.
Yeah.
Well, there's some trainer freaking out probably. You saw me in the gym. They'd pull the fire alarm and hose me down.
Well, there's a patient I was working with just recently. He's a firefighter, and he's got some pretty pronounced intolerance to lumbar extension and hip extension on the one side. And it's been persistent for, 10 months or so. So nothing looked terrible, no red flags on assessment. So it was trying to start to expose him to some of that, but he was also pretty guarded when it came to the idea of doing some loaded things like deadlifting or that sort of stuff. So we just had him do some bridges and with a lot of spinal extension, and I just cued him to do that, and he felt fine. So I said, do as many as you want to, and he did 100 and he felt fine. So that was cool. And I also was cognizant of people walking by in the clinic and probably for him, but there was a reason.
Yeah, if I can comment on that, the clinical challenge there is like, do you expose to get them to adapt, or is it time to like avoid and settle down? And that's where we all have trouble. I've done exposure-based stuff, and I'm like, shit, sorry, well, we should be backing off. And then the follow-up to that same circumstance was that he felt fine in the clinic, and then the next week we saw him, and he's like, I had to call into work the next day, and I couldn't do it. I'm like, oh shit, okay, well. Yeah. And I just kind of talked him off the ledge because he didn't want to do anything after that point. I understood why. This kind of guy doesn't miss work at all. And so I told him, like, okay, yeah, sorry, that wasn't the intended consequence. It gives us information. So we shot past that threshold. It was just this delayed onset. So we're not going to do that. We're going to do some other stuff that you feel okay with. And we're going to deliberately undershoot and make sure that you feel okay after the fact. But yeah, to expose or protect is the $1 million question, isn't it? Mm. Yeah.
I want to bring it back to talking to the students. Quinn had brought this up before. So what would you encourage students to do if they find themselves on placement working with an instructor who tends to adhere to a particular approach, or tends to think that these minutia or these details that lie in the weeds of biomechanics matter a lot, and say the student by means of exposure to work that people like you are putting out is coming to realize that maybe it doesn't matter quite as much, and that the things that do matter aren't that specific as far as the small details of biomechanics. How would you encourage them to have that? Well, how would you encourage them to conduct themselves in that situation? Let's keep it to a clinical placement situation for now.
Yeah. So when they roll their eyes, just make sure that they turn away from the instructor.
Oh, sweet. Excellent.
No, I had to go through this because remember, I went back to school after I did a master's, after I was at chiropractic college, after I was in practice for years.
You went through my program, my PT program.
Yeah. Yeah. So it's hard. But again, I would say don't, put the explanations on mute. But look at what that therapist does well and what the patient's like, and try to figure out why those people are getting better rather than the explanation. And so you can still, I can take courses from people that would probably really disagree with what I do, but I can still learn a ton from them because I can take their skill set and put it into my framework with the principles that I think. It's finding principles, right? And then how we apply those principles, we still all can do better. I still need more skills in how I apply my principles. So I would do, if they can figure out which is hard when you're young and you're learning, what your principles are, and then you can see that the therapist that you're supposed to be learning from, what can I take from him? What does he or she do well? So that's the idea.
For sure. And then it is, yeah. And I've talked to a number of people who are on placement with an instructor who treats very differently from how the student wants to be treating, or thinks that maybe things should be happening. But as the student, it is hard. You can't really disagree. You have to, I think, go along with it to a certain extent. But let's expand on that a little bit and say the student's now out of school, they're graduated, and they're their own independent therapist. How might you encourage them to go about having conversations, or if they should have these conversations about, do these things actually matter the way that we think they do, or are these other things that are much less complicated really the important things?
How can someone learn that on their own,
or should they have those conversations with their colleagues, especially if there are differences in opinions or approaches? And if so, how should they go about those conversations?
They can't change their colleagues. I've worked in plenty of clinics with friends of mine who practice differently, and that we're not going to change them. But again, you can look at the people who don't practice like you and still figure out what are they doing that's good. Yeah, so you can't. Don't worry. I would not get on that mantle. You're not going to change your colleagues. No way. That's why the internet's like, I felt so alone for so long. Like, I've been practicing like this for a long time, and it was different. And then, like, with the internet, I was like, oh wow, there's people like me. Right. And now I think there's more, so it's getting easier. So go on, go find your own echo chamber. No, don't actually. You know what? If I could give any advice to people, like, and I do this a lot, so maybe it's okay advice, is like, when you think you know something, go try to disprove it. Right. Like, so I believe we can adapt, but so, the past year I've been looking for research on what are the limits to adaptability, right? When should I protect more? Right? Sure. When should I back off? So yeah, like, you try to disprove your idea, find those exceptions, and then it'll still strengthen your principles if you know the exceptions. Yeah, never say something blindly. That's just stupid.
Well, we talk about challenging biases a lot on this platform, and something that we strive to do quite a bit, and that leads to often more of that feeling of uncertainty. But it's probably a good thing, because it leads to probably less saying stupid stuff blindly.
Yeah, maybe.
So I just like beating dead horses, and I get obsessed with things. So I was looking up that while you guys were talking about echo chambers, I was looking up tendon research, and it was it was in the Achilles tendon where they found a decrease in stiffness after an eccentric program only, and it was Morrissey et al.
I know. Okay, I'll email you about that. I know that paper.
Okay, cool. Yeah.
Talk to Andrew Vygotsky about that.
Got it. Okay.
It's an older paper. Yeah.
It's a 2011. Okay.
Yeah.
Cool. Because I want to be unconfused.
Yeah. Okay. We have. It's an outlier, and there might be a reason how they measure stuff.
Okay. I was going to say, if you're having a conversation with Andrew, then it's probably a methods thing.
Yep.
Okay. Sweet. Problem solved. There you go.
Nailed it.
And now I just need you to do that for the Consgard, where they did in the patellar tendinopathy literature in paper in 2009, where they did the heavy slow, and they actually found a decrease in stiffness, increase in function and pain tolerance, but decrease in stiffness. So I'll just need you to also dig into that a little bit more for me. Make sure that I'm not. Okay.
I found it was more a recent one. I know that as a Pete Malayaris paper, but he's only like the third or fourth author. Is he the first author? There's a more recent one.
Okay, well, there's also a Consgard one in 2009.
But they found decrease in stiffness in the patellar after the heavy resistance training?
Yeah.
Yeah, because it's like what happens with patellar tendons, there's this paradox. When you have a patellar tendinopathy, they become stiffer in people. That's what the degeneration does. When you have an Achilles tendinopathy, they become less stiff. So it might depend on where, like, and then getting people back to recovery, that's what you're correcting would be the idea. I think some people have told me that it depends where the tendinosis is, and it's different in a patellar tendon versus an Achilles. So this is paradox that patellar tendons become more stiff with degeneration and Achilles become less stiff, even though it's the same histological pathology where it is, it's the problem.
Right.
Yes, that's the difference. It's because it's a diseased tendon. Other than that, we don't know.
And then does it change what we do, knowing any of that?
That's what's funny. So that's why using stiffness as a metric is kind of silly. So, like, it doesn't quite make sense. But you're using a protocol to increase stiffness when, well, whatever, it decreases.
Do you find that using pain as a proxy of or a measure of outcome is also gets a little hairy if the person's goal is pain-free? Do you find a problem with that? I want to be pain-free. I've had pain for 5 years now. I want to be pain-free. That's my goal.
Yeah. I mean, I'm not pain-free. Like I've had, and I'm never injured, but I have like some persistent pain, like forever, that gets in the way of things. I think that's a really bad message, and we mess people up by telling them that they should be pain-free. Mm-hmm. That doesn't mean, but we should still be striving to decrease suffering and disability. I think that is where we can make the biggest impact. So when that pain is just ridiculously bothersome, that's the goal. But having it 0 or 1 all the time seems unfair to a lot of people. There's no doubt some people can be pain-free, but there's a massive subset who's going to have something. Mm-hmm. Do you guys know anyone who trains hard or that's pain-free everywhere all the time?
No, they're not training hard enough. They're not training hard enough.
Training hard. Yeah, exactly. Yeah. We're not even training hard. Yeah, that's just, it's really not fair. I think we set people up. And when people teach courses and say like they heal everyone in 1 week or 2 weeks and all these things, these are the courses I used to take. Like now you're just screwing young therapists because you make everyone feel like they suck just so they'll take level 2.
Right.
It's true. And it's sad.
Yeah, totally.
Greg, what do you got coming up? Projects, courses, papers?
The course, I like doing it. I'm trying to do it less because I want to see more patients again. We just moved like 6 kilometers to kind of the suburbs of Toronto, but not quite. So there's a workshop and I turned it into a gym and a clinic.
Nice.
So so that's what I've always wanted. It's like a clinic in my own house.
Yeah. So
that's that. So I'm going to be doing a little less traveling and then trying to put the stuff online, like a pain, an exercise course just for pain and injuries, that sort of thing, that complements the course and stuff like that. That's what I'm doing. I say that, but I've been saying that for a long time.
It seems simple in principle, right? Oh, I'll just make a few videos. I'll just do I'll just write it up, do the presentation. Yeah, no. Yeah.
No, because you want to get the structure. Things have to flow. There has to be a hierarchy, a framework. Yeah, that's the hardest. But I think I have the framework now. That took over a year. Get like a clinical reasoning protocol. That was the thing. It's not out there really for exercise. It's so driven by find a dysfunction and correct it.
Right.
Here's how you increase range of motion. Oh, no shit.
Where can people connect with you?
Depends what they want to say. Twitter to me is the best. I don't really like Facebook. I'm not on Facebook that much. That's where the old people are. But Twitter, I have my best, conversations there. I usually argue. I don't argue, like probably talk to people who are very similar to me, but we all still challenge each other because we're not certain about things. So I have a lot of discussions where, there's nothing like no one's throwing like I'm not throwing any flames anymore or anything like that. That's no fun. That's just useless. But you want discussions with people who are genuine and are we all have the same clinical problems. So Twitter's the best for that.
Cool.
But there's no shit storms anymore.
I know.
Those aren't nice.
There's lots on Instagram.
Oh, is that Instagram is just to track my tumbling progress.
Which is more than enough reason for people to follow you.
That's the only reason I use Instagram. It's like my diary.
Yeah.
Of flipping.
Keep it like that. Instagram it gives people it's not like Twitter because they have all the characters to use, but it's also not like Facebook because they can't link anything. So they don't need to. It's just their sounding board.
Yeah.
So
I put my vertical jump on there today. You guys ever use My Jump? That app?
I saw you posted about it, but I never used it.
I just screen capped doing it because I wanted to tell people how easy it was to use.
It's very useful. I use it all the time in the clinic.
It totally underestimates your real, like if you were to run and jump up and grab the rim, right? Like
it's relative though. So as long as you're testing, you can track progress, or track change as long as you're consistent with your testing protocols.
That's what I'm using it for. Yeah.
Cool. There you go. Plug for My Jump. Maybe we'll make them a podcast sponsor.
There you go.
Okay. That was great.
Thanks
It's so easy.
Yeah. Greg, first of all, thanks for so much for being on the show. First of all, second of all, and third.
My pleasure.
Jared, do you have any parting thoughts?
Nothing remotely profound. This was fun. Thanks, Greg.
Yeah.
Oh yeah, of course. That was fun.
Greg, any parting tips for the young listeners? Just that one thing that's going to make them the best clinician they can possibly be.
You know what?
There's only one thing.
Yeah, this is like super cheesy, but like, one, care, but like figure out what the patient really wants to do. Like really listen and like really know what they want. Like, what do they expect from you? It sounds silly, but I didn't ask that question for a long time. Like, what do you want from me? But like, but like, what do they really want? And then, all right, well, we can do that. Say yes more than no.
Because we tend to do what we want. We tell them to do what we want them to do, or what we think is right.
Totally. I think I did that for 5 years. I just rubbed the shit out of everything. Rub and crack.
Yeah. I want everybody to do the snatch and clean and jerk.
Yeah.
Awesome. Well, great conversation. Thanks so much for that, Greg. We'll try to link. We'll link all your stuff in the show notes so people can connect there and yeah.
Okay.
Thanks again, guys.
Thank you.
Thank you.